Central axis usually is the isotopes line. Everybody remembers what central axis is. Okay. So, you have, again, let me take this one. I'm gonna have to clean this board one of these days. Okay. So you have a beam coming down this way. Central axis is down the middle line of the beam. Here's your patient. And of course it's 3D. So you have a patient, central axis. This is your central axis of the beam. This is the central axis that you are treating to. So you've got a treatment beam coming in. How do you put it, how do you position your patient to match that beam? You have a light field, right? What's in the center of the light field?
Crosshairs.
Crosshairs. So where are the crosshairs? No, I'm asking
To the central axis.
where the crosshairs are in the beam. Central axis. They're in the center of the beam. So if you want to put a patient, a 15 by 15 square field onto a patient, to be accurate, you want to put it on the crosshairs. Your tattoo or your tattoo or your little crosses on the patient are where you want to set your central axis, right? That's where the lasers are. That's where your field light is. And the center of your field light is your crosshairs, which are on the central axis of the beam. That makes sense. Okay. So, only for square and rectangular fields. This is taking us back to the equivalent squares. Corrections made for irregular surface contours or inhomogeneities. Irregular surface contour. Give me an example of a patient with an irregular surface contour. Breast. Yeah, that is probably the most irregular surface that you'll get, or the most common irregular surface. So what happens if you're treating the breast? How do you position a breast? Everybody's seen it by now, hopefully. How do you position a breast patient for treatment with the beams? You got them on the backlog or the breastboard or whatever it happens to be. How do you position your beams? Do you just go ahead and do an angle and hope that it's right? So how do you position your beams? How do you set the patient up with your lasers for the breast?
Triangulate and then you.
Sorry, say again?
Don't you just triangulate and off?
Triangulate how?
There are two laterals and
The AP. So you have tattoos or marks. You put the field light on the AP. the lasers on the laterals, okay? You get those all triangulated, right? Then what? How do you angle it? Do you move the patient, if it's a right breast, do you move the field over and then angle the gantry? Or do you angle the gantry and then move the patient? So you move the patient across, or you move the bed actually, across, till you're at a set point. There's usually a measurement, right? A set point here, and then you angle to a set angle. And that gives you a tangent field, which you get a field here with some air over here, right? What do you call that? The air? Flash. Okay. So why are we, yes ma'am?
I'm having a really hard time with the breast placement. You know, like, I don't understand what you're saying, like, okay, so
Yep.
Initially, every time I've seen it, I'm still confused.
Right.
So like, first you line up the sides.
You line up, there's
Yeah,
usually an AP center.
But is there a mark there, or you just use it?
No,
There's usually a mark there,
there's usually a tattoo or a mark,
always in the center.
usually in the
I
center.
haven't seen that. Okay, and so,
So you have a mark here, and you have two marks, one mark here, one mark here.
okay.
Some places don't put that AP mark. I know
Yeah,
Gates
some
will
places
do.
they just.
Okay, so some
they
places
it
don't
where you're
put
gonna
that?
shift to.
Okay, that's.
Where I'm at now, they
I'm
do,
not
and
seeing
it
that.
confused me, cause I was
Yeah,
not
well,
used to having it.
That is unusual,
Not having it or having it.
not having it. The majority of places have an AP mark.
Okay,
So let me just hold for a minute. So how do these position the breast if you don't have an AP mark?
I think a lot of them had them in sim, but they just didn't line up to them very much, cause with
So-
breast, they kept saying,
How do they set them up then?
at Gainesville,
Yes,
they set them up with the lateral tattoos.
Uh-huh.
And then if they're doing vision RT, we make sure they match up to that, go to the
Yeah.
parameters on the computer, and then they do the CBCT and adjust from there.
so they don't set them up AP and then swing.
Sometimes they did, but not very often, because we had such,
Okay.
On
So
6 we did.
this is, remember what I was talking about with people relying too much on technology? This is what I'm meaning.
they rely on the
That's how we
CBCT.
so just explain to me
You can,
how you
okay,
would like.
so how I would do it
Okay,
is you have 3 tattoos or 3 marks.
Okay.
You have 1 AP, 2 laterals.
Okay.
You position your AP mark and your laterals. There is a set SSD that you go to, determined by dosimetry. So you set it up to that SSD.
and you would do it to that point, the
To
center
that
point.
point, yes. Then you have a shift, also determined by dosimetry, to put it onto the midline of the breast.
Okay, I've seen marks, they have
There.
marks on there, actual mark on the breast.
Yeah, on the midline here.
Sometimes it's down here, or, yeah, it probably is, I don't
Yeah.
really know,
So it should
But
be
it's
approximately midline
okay.
of the breast. So you move it, you shift it to that particular mark, wherever it happens to be. Then you check your SSD again to make sure, well, you see, if you're putting an SSD here, it's not gonna be the same
Right.
SSD here. So you would check that mark, because the dosimetry will give you
One for that one
one for
too.
that one also.
So maybe what's going on is maybe in sim, they use that, and then they mark this spot and they're just going to this spot. 'Cause I don't,
Yeah, so then what happens is you swing your gantry to a set angle, which is a tangent this way. And that should give you an SSD for treatment. And then when you've done that, you swing it all the way around to do the lateral.
But as far as setting up, that's done from the controls, right? Your angles are done at your.
You should be doing the first angle in the room.
Okay.
This is all if you're not doing cone beam CT or vision or,
We do cone beam CT every day.
yes,
So you're saying it'd be a little bit different if they do that? They use that more to set them up?
these should use both. You should position and then do your cone beam CT. The only problem with not setting up to the AP midline and setting up to here is that's all very well if you have a young lady or a lady who's extremely slim. If you have someone who is, as my mother said, I would say top heavy, or rather well endowed, what happens to the breast?
Well, she's very small, so maybe that, but at least that helps me so that when I ask questions, the questions are more intelligent
Yeah.
than, you know.
So
I
that's,
just was very confused and I didn't want to ask a question because I was like so confused that I didn't even have a
so
point.
that's the basis of how you would physically set up a breast. Now, there are departments that do a different way of doing it, but they're getting the same idea, a variation of that. So you have to be sort of flexible how you look at it, but that's the main way, because you are going to an oblique angle. You cannot physically set the patient up, lie them down, put them down, and then move it an angle, because your SSD is going to be screwed. One thing that you have to
Okay, so he
make
does go back in there when he sets that first angle. He goes in there and moves it by hand, and then he checks the SA. That makes sense now.
Yeah.
That's what he's doing.
Yeah.
Okay.
So the other thing with doing cone beam CT on a breast is that if you talk to the trainers who were teaching these people how to do cone beam CT, they do not recommend cone beam CT for breast. Simply because the breast moves and it's outside of the body, right? So the cone beam CT is not as accurate as it would be for something internal, because the breast tends to wiggle.
So what would you use instead?
Port films.
Yeah, I don't know. I'll have to look. I mean, I'm confused now. I'm in my head. I'm trying to think.
No,
Maybe
so,
he does
I mean,
that, and I'm thinking it's going to be.
if the department says we're using cone beam CT, it works for us, it's accurate for us, that's them. That's their technique.
I thought CBCTs were more clear in detail than port films.
They are.
So how would that not be more beneficial to do
Well-
on day of?
Well, you can do port film on day of.
But they're not as detailed to see.
No, they're not. But if you're getting an erroneous film, if you're getting an erroneous test, is it better to do a port film that you know is going to be accurate than a CBCT, which might not be?
How's the CBC not?
I've just mentioned, because the breast moves and it's one-sided, if you're doing a cone beam CT, they have suggested that it may not be as accurate as for other areas internally.
It seems like the port film would be the same way though, because
That's what I'm thinking.
if you take an image and then
Then it
it
moves.
moves,
No,
port
you
film
see,
same way.
because the cone beam takes how long? 2 or 3 minutes. you're doing a rotation, right? How long does a port film take to take? Quick. Like that. What are the chances of the patient moving or the breast shiggling?
Is that better?
Oh, you're talking about during the imaging itself, not
Yeah.
like moving
Yeah.
after the image, okay.
Yeah, I'm not
Okay.
talking about moving after the image,
Okay.
I'm talking imaging.
Right, okay, I see what you're saying. I don't know, he must be confident in it.
Well, no, that's fine, and
Yeah.
if they say, look,
Yes.
I don't care what the people that make the machines say, it works for us. It's accurate as far as we are concerned.
I
That's
wonder
their
too, he's got
thing.
an imaging background, so I'm wondering if he, he comes from, radiation tech first, before he did this. So I'm wondering if he's
The
just more
majority of
confident.
people, you'll find the majority of people who are employed in radiation therapy in Florida have that same background.
So do you think that just makes them more
No,
confident in their?
Not really,
I
not
think it
really.
makes a difference in some cases too with how much tissue you're irradiating. 'Cause I know I've heard them say, yeah, there could be some movement, but this is a whole breast anyways, so we're gonna be getting it regardless, as far as it not being.
Yeah, that's a
Within
radiography background.
But if
That's-
it's like a boost or something, obviously they want a more detailed image to get it down.
Yeah, well, the fact that they're saying that, I don't want to contradict them. However, the fact, what are we worried about when we're treating a whole breast? The lung underneath. We have to treat the whole breast in the majority of the cases. So therefore, we have to treat the lung, little sliver, centimeter-ish. If they're saying, and you didn't hear it from me, if they're saying that just because it's a whole breast, it doesn't matter if there's a little bit more getting irradiated, I'm sorry, that is wrong. Radiobiologically and radiation safety-wise, that is incorrect, shall I say.
You didn't hear from me either.
So anyway, you
We'll just have
should,
each other's backs on
it
this.
really doesn't matter what you're treating. You have to make sure that you're only treating the area that you want to and not treating the area that you don't want to.
I'm sure there's also details that I'm not getting the whole,
Oh, yeah.
that they know they're not saying completely
Yeah.
too, so I'm sure
Yeah.
they're not just winging it.
Right, that's the way I feel. I mean, there's
Yeah.
things I'm missing.
Oh, yeah,
And
You
the
know.
stuff we pick up on is like red flag,
Right.
but there's something else that brings that red down
Right.
to a
Yeah.
gray that we're not catching, so.
it's sort of light pink.
Right,
Yeah.
exactly.
Yeah. So, yeah, there are certain things that you may misconstrue,
Right.
shall we say.
I'm aware of that for sure.
So just, obviously you guys are paying attention, otherwise you wouldn't have figured this out. You have to know what you don't know. You have to figure out what you don't know first. And then we'll figure out how to make it that you do know.
And how to properly ask so that they know
Yes.
what we're asking.
Yes, exactly.
A lot of times I'm just
Because-
like, I don't even know how to word this.
Yeah,
Sorry.
because if you don't know what you need to ask, you can't ask it.
And that was my problem with the breast, and it's
So-
been 3 different ones, and I keep watching, trying to think, okay, something's gonna click,
Yeah.
and he's very good about answering questions.
Yeah.
But if you, like Molly said, if you don't know what question to ask,
Mm-hmm.
you're not gonna get the answer you need.
Exactly, so, yeah. So that's the irregular surface contour. So you have, how do you make up for the irregular surface contour? What do? Let's do 2 things. Let's say non-IMRT first. And then we'll do IMRT. Okay, let's do IMRT first. What because it's a little more complicated with non-IMRT. Since everybody, I presume, is doing IMRT for breast. Yes, yes, and yes.
Most.
Okay. Pardon?
We've had a few, but not many.
Right, okay, so let's do an IMRT breast. How do you make up for the contour? The irregular surface?
MLCs and digital wedges.
What?
MLCs and digital wedges.
MLC and digital wedges, okay? Is that IMRT?
MLCs,
Yeah,
You don't use digital wedges for IMRT.
well, isn't that the actual MLCs, the digital wedges, the MLCs?
In some cases, yes, but that is going to be used for non-IMRT. So what do we use the MLC for during IMRT?
Shape the beam and
Shape the beam
change the intensity.
and change intensity. So you're shaping the beam not with the digital wedges or the dynamic wedges as some people call them. You are using the MLC to actually physically shape the beam by alteration of the intensity. Make sense? Kind of, sort of.
I'm just confused because when we do IMRT breast, there's this thing on the screen and it'll say
Says,
wedges on and then
Wedges
it'll
in,
pause
wedges
and then
out.
it'll be
Yeah.
wedges off. So I know there's something about
And
wedges
I've been
going
told
on.
that was the MLCs.
well, it does,
changing.
yeah. The digital wedges or the dynamic wedges are used instead of physical wedges. Physical wedges are what? Heavy.
Physical wedges put in.
They are physical wedges wedge shaped, and you actually physically place them in the beam. Now, dynamic wedges are software that allows the MLC to work as a wedge. So it will start off either fully open or fully closed. And as the machine works, it will open or close the wedge. We'll say that they start closed. Then the MLC will open the wedges very slowly, depending on which wedge they are using. So if it's a 60-degree wedge, they will open extremely slowly. And they'll work their way across the beam.
So
You'll
it's the
see
amount of
that.
time that the beam is, or the
On.
tissue is exposed to the radiation.
Yeah. Yeah.
That depends on, that determines whether you're using 45 or a 60
Yeah.
or.
Yeah. So if you're using a 15-degree wedge, it will open a little faster or much faster than if you're using a 60-degree wedge.
So that's just the jaws or the MLC?
That is the MLC is one set of jaws.
I thought the jaws were solid, they were a different piece than, you had the MLCs on one level and then you had the jaws.
Jaws
that
on
were-
the other level.
Right.
Yeah. So the jaws usually work. If you don't have MLC, you can't have dynamic wedges. The Electa machine has a different type. They don't have actual dynamic wedges. They have a universal wedge. Has anybody ever heard of that? Universal wedge for an Electa. That can actually make a different wedge as it goes along. I'm not really familiar with it, but I've seen it in use. I'm more familiar with the dynamic wedges, which are actually the jaws moving in and out. But it can also be programmed to do the dynamic wedges. The MLCs can be programmed to do that as well.
So you can do both, you can have the MLCs for shape and the
Yes.
jaws for the wedge,
The wedge, yes.
and that's IMRT.
No,
That's just for conformal.
that would be conformal. Now, if they found a way to do IMRT breast with a wedge, that's fine.
I don't know, that's
But
what
you
the screen
should-
said.
What?
I
That's what
don't
the
know,
screen
that's just what
said?
the screen said.
Yeah.
She said, when it pauses, the wedges are doing whatever, and I'm like, so I just assume they're using the wedges. I don't
Yeah.
know.
Well, they could be using, if they're using the IMRT as a wedge, that's what it could be, is that they're using the IMRT, the MLC to shape the beam, but it's labeled as a wedge. Ask them next time you're in.
Listen,
To
I work
clarify.
with somebody that if you ask her, she's like, I don't know, look it up. So how does that help me? So.
It seems like it'd be hard for them.
I'm like, well, I wouldn't be asking you you think I haven't tried to look it up? I'm asking somebody who's in the field currently.
Right.
Yeah,
Yeah,
That's what I used to tell my students when I didn't know the answer.
exactly. Well, I don't think that's the case in this
Yeah.
instance. I mean, I think that they want you to do the work and look it up, and for me, looking it up and finding it does make it stick better than somebody just telling me.
and showing you.
Right.
Yeah.
But if I've looked it up and I can't find it, then I need.
Yeah,
You know,
exactly.
additional.
So let's go back to the 3D conformal. What's the difference between 3D conformal and MLC? And IMRT?
Static?
No.
No?
You can do IMRT static. That's
Okay.
something that we have to get our brain
Yeah, 'cause I'm
worked
thinking
around,
of
guys,
ours. Okay.
because 99 times out of 100, most of you will do IMRT with a VMAT, right? That is a kind of IMRT, is VMAT. You can do IMRT static, which would mean you do one field and the MLCs would move around, then you'd stop it and you do another field and the MLCs would move around, and then you do another field and the MLCs would move around. That is a static IMRT. It's easier to do, for us, on the floor, to do an IMRT VMAT. Because one, you don't have to go in and check the patient. Once you start it, it goes, and you're sitting there watching the machine like a lemon. Hopefully not that way, but you're watching your patient, making sure that nothing hits your patient. So let's go back. What's the difference between an IMRT and a 3D conformal?
Well, it sounds like one uses wedges and one doesn't.
Could be,
Mhm.
yeah.
The
Mhm.
use of MLCs.
3D conformal uses MLC.
But they don't move, right?
They will move into position, but they
Not
don't
during.
change during the treatment.
Is that step and shoot?
No, not necessarily. Step and shoot is also a type of IMRT. 3D conformal is if you have a breast, you're doing tangent fields. What does the MLC do in an IMRT breast field? You're setting up to medial. You come outside, switch the machine on. What does the MLC do? The machine is static, right? It's not a VMAT, correct, for the breast? Yes, no, maybe, sometimes?
For 3D conformal only? Is that what you're talking
No,
about?
I'm asking the difference between a 3D conformal breast and an IMRT breast.
So then 3D, it would move
3D has like an open
while being's
field.
on.
With MLC shape, yeah. So the 3D conformal, you'd come out, you position your patient, you come out, you would have the diagram of the MLC shape on it. There might be a wedge, there probably is a wedge, a dynamic wedge. You'd hit the button, the MLC would not move. The only thing that you would see moving is the wedge going in or out. Oh, just wandering through. So that's the difference between 3D conformal and an IMRT. 99 times out of 100, that is what happens. So the MLC moves in between, even if it's a static field, the machine will move, the MLCs will move. And that is shaping the beam by use of the MLCs. It's also making the beam, giving the areas of the beam different intensities. So far, so good.
So 3D conformal is when the MLCs are moving,
No,
it's shaping the beam, then the beam comes on and they do not move. Beam is not on with,
where, you've lost me. Okay, so you're saying the MLCs move. What do you mean by move?
to shape it in the
Okay,
shape that you want.
so when you're programming the patient and you bring up Mrs. Smith, right medial breast, the MLCs will move into position, right? You position Mrs. Smith, get her all organized, get the field size, make sure it's okay, make sure the SSD is okay and everything's hunky-dory. You come outside the room, you hit the button, what happens?
Beam comes on.
The beam goes on. Does the MLC move?
No.
No. If you have a wedge in,
Moves.
dynamic wedge, it will move,
But not the MLCs.
not the MLC.
And then when you're switching to the laterals, beam off, nothing is happening while it's rotating.
Well, if you're rotating the gantry from outside of the room, you will notice that once you program the lateral, Mrs. Smith's right lateral, you can rotate the gantry and the MLCs will automatically go into the shape for the lateral,
Where they will also stay in that position.
where they will stay in that position, yes.
So beam stays on the entire time.
IMRT VMAT does, yes.
But the beam doesn't stay on the whole time, right? Sometimes won't it turn off depending on what spot it's in? To save or, I mean,
This is where the water is murky.
see, I
Okay,
thought that
so-
CMAT will turn on and off, the beam will turn on and off.
Are you using, do you know if you're using step and shoot or you're using oh dear, dynamic?
Well, I haven't used it, I was just
It
thinking.
pause in between arcs,
Pardon?
like in between, like
It'll
different
pause
motions, it
in
will
between,
pause.
if you have 3 arcs.
Yeah, so that's
It
what they
will
mean,
pause
like,
in
yeah.
between 3 arcs.
It's gonna turn off.
But if you are doing an arc, then it will not turn off
Yeah, it'll be on the whole time.
on the whole time unless you are skipping for a hip prosthesis or something. So if you're doing, oh my goodness, okay. So if you're doing a patient and he has 2 hip prostheses, right? So you're doing an arc and the treatment is merrily going on and you get to here, the gantry will continue, but the machine will switch off, or the radiation will switch off.
That's only done for that?
Yeah,
And it's called what when it does this? Like, what is it?
it's called a skip.
So it wouldn't do that for a spine or anything? It wouldn't do that for?
It can
Oh, so,
be,
okay,
it can be programmed to skip anywhere.
okay.
So if you didn't want to treat the spinal cord, you can have this going around and it will, you have a beam here and it will, the gantry will continue, but the radiation will switch off and then switch on again.
I was trying to figure out, we're doing a patient who is having radiation for rectum.
Yep.
And she has like 9, I mean, it's a lot.
9 fields.
And I asked, you know, what would be the reason the doctor would choose this over doing ARC to me?
Yeah.
Because it seems like if you, I mean, it takes a long time. He says it really doesn't take any more time to do it this way. So, you know, maybe that's true when you're.
So he has how many fields?
She has 9, I think, but are there I mean, it seems like more than 9, and I don't quite know how to read the thing
You're
yet.
using step and shoot.
Okay,
So what step and shoot is that you have, say we've got 9 areas, right, all the way around the body. You start it here, and it will, the MLCs will be in a certain position. You have X number of monitor units, and then it will stop, and the MLCs will change.
so is that
And then
IMRT?
it'll stop. That is a type of IMRT, yes. It's called step and shoot.
So do the MLCs move while you're shooting? I can't remember whether they moved while they were
No,
for each field.
no. This is why you have subfields.
Okay.
So you start with one relatively large field,
Mhm.
and you have the MLC in position. You do a certain number of monitor units in that position. Then you stop, the machine stops, and it will change MLCs. It will start again. And then it will change MLCs again, and it will start again.
That sounds just like 3D conformal to me.
No, it's not. It's a type of IMRT called step and shoot.
So you're saying it's IMRT if it's within the same field and you're changing beam intensity?
Yes.
Okay, so then 3D.
So that makes more sense.
Yeah.
that's the difference.
Yeah.
So 3D conformal is
Within one field.
forms it shaped, freezes, shoots beam, turns beam off, changes to a new position. That's 3D conformal, then does that again.
As long as you're changing fields. So if you're doing a field here and you have 9 little subfields or 6 little subfields, then you're doing one field, it'll alter, do another area, or doing the same field, do small subfields. That is called step and shoot.
So what would be the reason somebody would choose that over doing the ARC, the VMAT?
It's a physician's preference or a physicist's preference.
But you think the level of care, the level
It's exactly the same.
Okay.
And it does take longer. Don't worry about it, it does take longer.
He said the other reason is the machine that we're using really doesn't do as well with VMAT as the one up in Brunswick. But to me, that guy doctor works both of them. I guess he could have chosen to send her up there if
Yeah,
he wanted to do VMAT.
well, I think, it's, what type, is it an Electa?
No, it's a
Variant?
25.
Variant. Variant
It's
machine,
an
yes.
older one.
So, it's not the actual machine, it's the software that they wish to use. So some physicians and physicists prefer to use step and shoot. Not sure why, I've used it and it takes a long time.
Yeah, like I was glazing over towards the end.
If you compare a step and shoot prostate to a dynamic VMAT prostate, it takes about a third as long.
I mean, it's still pretty fast anyway, you know,
Oh,
what
yeah.
you're saying,
Yeah.
but it just seems to me it seems to me there would be less chance for error or something with the VMAT than there would be constantly changing that.
Well, it's just the way it's planned.
Yeah.
Because the VMAT changes automatically. Whereas if you're doing a step and shoot, you can actually watch it change in, I won't say slow motion, but slower than the VMAT does. Because the VMAT, if you try and watch it and see where it's moving, it's very difficult to follow what it's moving to.
Because they're constantly in motion.
Because they're constantly in motion. Now, for 3D conformal, if we were doing 6 fields with step and shoot, you'd have 1 field and you'd have 3 or 4 subfields, right? And then you go on to the next one and you do the same. With IMRT, with 3D conformal, you'd have 6 fields. You do 1, you move the gantry around, do another, move the gantry around, do another, move the gantry around, do another.
So if there's no subfields, that's 3D conformal.
That's 3D conformal, yeah. So you would set your MLCs to the shape that you wanted, treat, and then move. Set the fields, set the MLCs to where you want them, and move.
Are subfields the same as field in field?
Kind of. Everything is kind of. It is the same technique, yes. Okay, so inhomogeneities. Why do we need to worry about inhomogeneities? What are inhomogeneities? You've got lung and bone. So normally, if you're treating a patient, what type of tissue do you go through? Soft tissue, right? If you're going through lung, what kind of tissue are you going through? Or what kind of, tissue. It's not actually tissue. What are you going through when you're treating lung? Air. And bone, obviously. So if you're going through a hip, for example, the majority of your field would be bone. If you take it to the extreme, you have, if you're treating a breast, go back to breast. I don't know why we keep going back to breast, but it's easier to do. So if you're treating a breast, you're going through a little bit of lung. You're also going through a little bit of bone, right? Where do we find the bone? Sorry? Yeah. So, you have these inhomogeneities. Lung and bone. So what do we do with them? Most of the time you try to ignore them, but that doesn't work. The best thing about computerized treatment planning is that the computer will allow you to look at the inhomogeneities, both lung and bone. It will allow you to do that. Now, it could be when you're treating the breast, most people would say, we're ignoring it. We're ignoring the inhomogeneities because you've got a little sliver of lung and you've not got much bone. So a lot of places will say, just ignore it, don't put the inhomogeneities in. But you have this beautiful, very expensive piece of software that will allow you to put in an inhomogeneity for lung, an inhomogeneity for bone, and everything's good. You would never do it if we were doing hand planning, believe you me, we'd never do it. Okay, so build up. Those in this region, this is called what? Build up region. What is this like? Mouth one more thing. What is this region called? It's called the build up region. What does it lead to? The stores in this region gradually increases and builds up until it reaches a certain depth and then falls off due to the increasing thickness. Dmax. If you're looking for another way to say Dmax, it's the end of the build-up region. Build-up region starts at the skin and you have a certain amount of tissue before it reaches Dmax. And then after Dmax, it starts to reduce again. Okay, single field, POP, parallel opposed pair. 3 fields, 4 fields, and etc. Okay, so single field. We've been over this before, but we may as well do it again. What would we use a single field for? Not electrons. I've got it there before somebody mentioned it. For, yeah, spine. So if we do a single field spine, has anybody done a single field spine yet? Okay, so if we do a single field spine, this lady comes in, or this gentleman comes in, and he's got pain in his back, and the doc says, yeah, you've got a metastasis in the thoracic spine. We want to do one single field to the thoracic spine. What would be the easiest way to position your patient to do a single field thoracic spine? Come in.
Prone, maybe?
Prone? Yeah. Why would it be easier than setting them supine?
You don't have to avoid all those organs in the anterior portion of the cabin.
Okay,
You can visually see the field.
you can't visually see the field, yeah. So it's easier if you can get this gentleman lying on his belly. And you get him positioned with his hands up above his head down, sort of like that, and treat the thoracic spine. The other thing that you can also do when you're treating prone is normally what you would be asked to do is center on the spine. So that was me. Didn't come from the club. The other is to center on the spine. If they're lying supine, how do you make sure that it's centered on the spine? Well, there is a way.
You'd have to take port films or something? I don't know.
Yeah, or you could do actually, if you have a treatment, a machine that does KV images, that's something that you could use a KV image on. You could use a KV film or KV image to check that your central axis is along the middle of the field, the middle of the spine. But if he's lying prone, how do you check if he's centered on spine? Palpate. You can actually palpate your spine. It's easier if you're lying down. But you can actually feel the center of the spine and make sure that the patient is centered. It's ideal. What are the chances of somebody with spinal met being able to lie prone? Yeah. Some people actually find it easier to lie prone, as long as they can get up and, what's more important, get back down. But if they can lie prone, that's ideal, because you can do a single field. It's very easy, very simple. You don't even need films. That's the kind that you love when they come in for an emergency and they say, single field spine, patient can lie prone, and you think, you don't have to worry about films. That is for center. But if you're coming in and you want to make sure that it's on the correct vertebra, then you obviously have to do films. Okay, so that would be so parallel opposed pair. What would be the treatment that you might do that with? What kind of treatment might you do a parallel opposed pair? Sometimes it's a palliative treatment. What type of tumor might you have palliation? Okay, let's go back to the beginning. When you're doing palliative treatment, what are you trying to help? You're trying to alleviate symptoms, okay? What kind of symptoms? Pain, which would be the single field spine, right? Sorry, you said something. Swelling, okay.
Breathing pain.
Breathing. What kind of treatment would you use for breathing? What area would you treat? Lung. What kind of treatment is a parallel opposed pair?
Lung.
Lung. Ooh, it's like drawn teeth. So yeah, sorry about that. If you're doing a patient with a carcinoma of the lung and you're doing 3D conformal, you would start off with an APPA field. And then do what is called an off chord. Sometimes what we would do is start off with a 3D conformal APPA and then do IMRT for the plan, for angled fields.
Say that again.
Normally, you would treat an APPA field, sort of for the primary treatment. And then instead of doing angled fields of chord, you would do IMRT, say a VMAT, for the smaller area.
So 3D conformal for the APPA.
Because you don't do IMRT APPA. So APPA is always 3D conformal, always.
So if you're doing APPA, is it just one large field, front, back?
No. You can do smaller fields with MLC and maybe a wedge.
I think my question has been, are we doing both ones at the same time?
No. You very seldom do what is called a lung bath. You would treat the area where the tumor is with an APPA field. So if the tumors are here, then you would do maybe a 10 by 12 field, APPA, to a set dose. And then he would be planned, or the plan would be being done to start after a certain.
So you're saying that would just be palliative, the
Not necessarily. If you're doing a palliative field, then it probably would just be APPA. But if it was a curative patient, you could still start with an APPA and then go on to a plan for IMRT for the rest of the treatment.
What would be the reason to do that? Why not just go straight to IMRT?
It could be that you're trying to, perhaps the patient's not breathing very well. So if you give them a relatively large area treated first, and that will reduce the tumor, so it would make it more comfortable for him to lie there for a VMAT.
So that would still be considered parallel opposed, an APPA and an IMRT?
No, APPA is the parallel opposed pair. Once you get into anything else, that's not an APPA. Part 1 would be an APPA. Part 2 might be a VMAT or some other kind of IMRT fields.
You
If
wouldn't do any laterals, if you're doing like an APPA and a right and left lateral? Isn't that 4 field box or?
No, 4-field box is an APPA, it is a pelvis. You don't do a 4-field box in the chest. Okay,
Why is that? Like, why is one better to do than the other?
if you're doing angles on a chest,
You have to do chest, right?
you don't have to begin with. What are you worried about when you're doing an APPA?
Goes to the spine.
Dose to the spinal cord, right? So once you set the dose that is what the dog wants, which is 4,000 or 4,500, normally they'll stop about 4,000 just to be safe. Then they'll have to either do what is called an off cord, which would be obliques. An AP and 2 obliques, for example. That would take it off cord. That would still be a 3D conformal.
But not a pop.
No, because if you're doing obliques, it's not a parallel opposed pair.
Now, if it was palliative and you're not going up to 45, could you do a 4-field block on that area of the lung?
You could, however, that would mean, if you're palliative, that would mean have the patient's hands above his head. And if they're palliative chest, they may not be able to do that. So that's why we usually do an APPA chest if they're palliative only, if you know they're going to be palliative, their hands are by their sides. So you either do an APPA for the first part and then obliques for the second part, or you do APPA for the first part and then do IMRT for the second part. And why most people do IMRT for the second part is they get paid more for IMRT rather than 3D conformal. If you're doing an APPA for palliative, they won't allow you to then go on and do IMRT because they will not pay for IMRT for palliation.
So for palliative, you just stop at APPA, you don't do any other fields?
Usually not, because what's the basis of palliation? Treat the symptoms. So you're trying to let them breathe a little bit better. Why?
So that they're comfortable.
So that they're comfortable. And you're trying to give them a quality of life because they don't have a quantity left.
So the second set of fields would increase the quality of life for palliative?
What do you mean?
If they're having trouble breathing
Yeah,
and you're only doing an APPA,
yeah,
that's more beneficial to them for a palliative situation than an APPA and
yes,
obliques.
yeah, because it would take longer. So you do the APPA first and then go on to a plan with obliques. You never start with obliques. You always start APPA on these patients. And then if you go to obliques, that's another 2 weeks or 3 weeks. The patient's on treatment for 5 weeks.
Why would it be more time, more weeks?
Because you want to do as little as possible. You want to do it as simply as possible because you don't want to put the patient through all sorts of calisthenics with their arms up, with arms behind their heads or something like that. You want to keep the patient as comfortable as possible for the shortest period of treatment time as possible for the shortest period of overall treatment.
So if you added the obliques, that would have to be at the end? It would be simultaneous
No.
with the
No, we
parallel?
never do them simultaneously. We always do APPA first, and then if necessary, do obliques. But that would give, if the APPA takes 3 weeks, and then you want to add another 1,000 on with obliques, that's another 2 weeks. So that's 5 weeks. You've got this patient coming back and forward where they don't really need to. It's not good practice to have a patient who's palliative having treatment for 5 weeks if they only have 4 months to live. Does that make sense? Okay. So, having said that, 3 fields. 3 fields would be an APPA or an AP and 2 obliques. If I said to you we do an AP and an APPA for the first 2 weeks, or 3 weeks perhaps, and then do an off chord of an AP and 2 posterior obliques, what would I be treating?
Off chord AP.
Off chord. off chord AP and 2 posterior obliques. Okay, let's do this. Let's take this away. And take that away, and him away. And so, we've done an APPA, right? We've done an APPA. Chord is here. Now we're going to put a tumor there. Now we're going to continue with an AP and 2 obliques. What are we treating? Actually, it's probably, hang on a minute. Oh. What are we treating?
Breast?
Say again?
Breast?
Breast?
No?
No.
Oh.
Esophagus?
Esophagus. Yes. Esophagus. How did you get that? When I moved my butt back?
Lined up with the spine.
Yeah. So because the esophagus is, go away, I'm not answering you. I hope it's nobody else. Anyway, where is the esophagus?
You're not asking for vertebral level, are you?
No, I'm asking
Okay.
for anatomical positioning.
Okay.
Midline? Yeah, it's midline this way. What about this way? What about AP,
Close
PA?
to the spine,
Pardon?
closer to the spine.
Closer to the spine, yeah. So, is it behind the trachea?
I feel like I don't think it is.
Yeah, that's probably what.
That started.
Uh-huh.
I'm trying to think of the last time I choked and how that felt, where it felt.
It is behind the trachea. Okay,
Yeah,
so
so
it
it
is,
is right, they're going right through the front, so
It
that
is-
would suck if they went through your,
it's
Esophagus.
posterior. It is posterior to the trachea, so it is actually fairly posterior. So it's easier, more common to treat the esophagus, first of all, with an APPA, to the spinal tolerance dose, is what we call it, which is what? 4,500. And then treat AP and 2 posterior obliques, because it is more posterior. You could treat anterior obliques, but it's more problematic, so you treat posterior obliques.
How many fields is that considered? So if you do
EPPA is 2
two
fields,
fields,
and then the next set of fields
is three.
is 3 fields.
if you wanted to do it VMAT,
You could do it.
is it still considered 3 fields?
No,
No.
VMAT is VMAT. It's a rotation. Doesn't count as fields.
It confuses me.
This is non-IMRT. This is all 3D conformal. So ignore IMRT for the moment. So, 4 fields. Molly, your four field box. What's normally treated with 3D conformal with a four field box?
You already said pelvis, so I'm going with pelvis.
You can treat prostate, bladder, cervix, uterus, rectum, anything. Anything in the pelvis, you can treat with four fields. Why can we treat with four fields and not worry about spinal cord?
Doesn't go down that far.
Doesn't go down that far. So what's the, is there, difficulties in doing a four field box?
Organs at risk,
What are the organs at risk?
and what you're treating, pretty much all of them.
Okay. So if you, the same thing applies if you had a prosthesis, a hip prosthesis. What would we do? Remember, we're doing 3D conformal, we're not doing VMAT or IMRT in any shape or fashion. If we had a prosthesis, now we've already said with the IMRT, you can, or the VMAT, you can actually stop the radiation, but the gantry continues, right? What would we do in a 3D conformal situation? Could we treat laterals? You do an APPA and two laterals, or two sets of parallel opposed pairs, basically.
You can just shift your ankles, you can do like 4 obliques.
You can do 4 obliques, yeah? Or you can do an APPA and 2 slight anterior obliques to avoid, if he's got 2 hip prostheses, you can do 2 obliques. And that would not be 2 pairs of parallel opposed pairs. That would be 1 pair of parallel opposed pair, APPA, and 2 anterior obliques or 2 posterior obliques, depending on what you do.
So if you did 4 obliques, that would not be parallel,
It would be.
it would be.
Well, as long as your obliques were,
9
Parallel.
obliques, yeah. 9
so if you have 2 parallel opposed going this way and 2 going this way, then you still have parallel opposed pairs. It's just they're cattywampus, yeah. Makes sense? Cool. Give you a break. 20 minutes, guys, so 22 on this call, on that call.